Hello, I'm Dr. Carlos Schenck from the Minnesota Regional Sleep Disorder Center, the Hennepin County Medical Center, and the University of Minnesota Medical School in Minneapolis. And I'm here today to discuss our discovery and the impact of REM sleep behavior disorder. Unfortunately, I'm here without my colleague and fearless leader, Mark Mahaud, who is quite ill but on the mend. I started my career in sleep medicine in September of 1982. The Minnesota Regional Sleep Disorder Center had been formed in 1978 by the Department of Neurology here at Hennepin County Medical Center, and they had the great vision of forming a multidisciplinary sleep disorder center. And they reached out to my chief of psychiatry at the time, asking for a member of our department to join the team. And I was always interested in neurophysiology beginning in medical school, and I thought this would be a great opportunity to pursue my interest in clinical neurophysiology. And I joined the Sleep Center in September of 1982. And as fate would have it, the second patient that I evaluated was on September 11th, 1982. And so for me, the date September 11th has multiple meanings. So the gentleman I interviewed on September 11th, 1982 was a Donald Dorff from Golden Valley, Minnesota. He was a very pleasant man, age 67, who complained of violent moving nightmares, which I think was a wonderful term for describing the REM sleep behavior disorder. He had never been a sleepwalker during childhood, and he actually grew up in a small room with 3 brothers and 2 bunk beds, and if he had done any type of activity during sleep, his brothers would have let him know. But Donald had very uneventful sleep, but then shortly around the time of his retirement, he started having violent moving nightmares where he would act out dreams, thrash around, hit his wife, leave the bed. And then he had a dramatic episode one night in which he was a football player. He was actually a halfback, carrying the ball through the line of scrimmage, and he ran into a 280-pound defensive lineman who stunned him as he smashed Donald into the ground. And that's when Donald woke up in his bedroom after smashing into his dresser. And he gashed himself, drawing blood. So he saw his physician, who found no medical basis for this problem, and at that time it was logical to then send him to a psychiatrist, wondering if there was some kind of psychiatric disorder emerging during sleep, and the psychiatrist found no psychiatric basis for his problem. And at that time there was the beginning recognition of the existence of sleep disorder centers, so his physician thought, well, let's send this man to the Hennepin County Medical Center Sleep Center. And that's how I evaluated Mr. Dorff. 5 nights later, on September 16th, 1982, we studied him in the lab, and I was very curious. And so I stayed all night, and sure enough, during what appeared to be rapid eye movement sleep, Donald would jerk his limbs, throw punches, shout, sit up, and basically he would engage in behaviors that he and his wife commented that he would engage in at home. The next morning, Mark Mahaud came in to read the record with our chief technologist, Andrea Patterson, and I participated in their debate, and they played devil's advocate with each other, going back and forth, challenging each other to say that this was not REM sleep. And in the final analysis, they both agreed this was REM sleep, but without the usual muscle atonia, or muscle paralysis. Fortunately, there was an animal model of RBD created in 1965 by Michel Jouvet and his colleagues in Lyon, France. They were trying to find the center in the brainstem that generated REM sleep, and they created electrolytic lesions in the lateral dorsal-pontal region. And for 2 weeks, these cats apparently had no REM sleep, but then they had the return of REM sleep, which was called paradoxical sleep by the basic scientists. Everything checked out for paradoxical or REM sleep except for the muscle paralysis, and these cats acted in what the authors described as hallucinatory or oniric behaviors. They would chase imaginary prey, they would attack imaginary prey, they would search around for imaginary objects, they would have orienting behaviors, they would have minimal twitching, and in fact the animal model in all its different categories really previewed the human REM sleep behavior disorder by a factor of 17 years. So then after 1982, we followed Mr. Dorff, and he had no neurologic basis for his REM sleep behavior disorder, so we call this condition idiopathic. But we had to treat the patient. He came to us not because he had an interesting condition, but because he wanted therapy to prevent himself from gashing himself and disturb his retirement. He was an avid golfer and did not want his sleep disturbance to affect his golf game. So we searched around and initially prescribed tricyclic antidepressants, which made sense because it was a REM suppressing agent, but this logic did not work out, in part because we could not increase the dose sufficiently high to see if we could fully suppress REM sleep. The anticholinergic side effects of the tricyclic antidepressants prohibited us from going higher. And at that time, we also realized that Mr. Dorff had periodic limb movements of non-REM sleep. And at the time, those were called nocturnal myoclonus. The literature in neurology that clonazepam could control the sleep disruption associated with nocturnal myoclonus. So we thought that if clonazepam could help one sleep motor disturbance, the nocturnal myoclonus, perhaps it would help what we were calling then the REM movement disorder. And lo and behold, clonazepam worked as a charm. I should also point out that we realized, beginning with Mr. Dorff, that RBD was a dream disorder almost as much as a sleep behavior disorder. Mr. Dorff was acting out distinctly different dreams that he had before he was acting out any dreams at all. Dreams of confrontation, attack, really unpleasant scenarios, sometimes sports dreams, but they ended up badly as he got smashed by a very large lineman and he drew blood. So that was intriguing, and also what was intriguing was that clonazepam, beginning with Mr. Dorff, controlled the abnormal dreaming of RBD besides the abnormal behaviors. And that made us realize that perhaps there was a common pathophysiology generating the abnormal dreams of RBD besides the abnormal behaviors. So over the next few years, we identified 4 other patients, and ultimately in 1987, we called this condition the REM sleep behavior disorder. And in 1986, we still called this condition the chronic behavioral disorders of REM sleep. And a total of 5 patients were reported in the journal Sleep in 1986. Only Mr. Dorff was the idiopathic patient. The other 4 had diverse neurologic disorders involving a subarachnoid hemorrhage that triggered the RBD, atypical dementia that turned out to be Parkinson's disease and dementia that triggered RBD, and also Guillain-Barré syndrome. And the final neurologic disorder was an olivo-pontocerebellar degeneration, another brainstem condition. So we recognize that diverse neurologic disorders focused on the brainstem and the lower brain regions could trigger the onset of RBD besides an idiopathic variant. We also recognize that RBD was a disorder of predominantly middle-aged and older males. So that was another intriguing aspect in terms of the male predominance and the middle-aged and older adult age frame that posed a risk for RBD. So after publishing our initial 5 cases in 1986, in 1987 we published 10 cases in the Journal of the American Medical Association, and that's when we came out with the official term of the rapid eye movement sleep behavior disorder, or RBD, and that was then incorporated in the original ICSD, the International Classification of Sleep Disorders, in 1990. In 1987, I produced, along with Mark Mahauld and the Minnesota Medical Research Foundation, a video documentary film on our first 30 patients of RBD that demonstrated the range of behaviors documented in the sleep lab. And I want to show a segment from that videotape now.
Hello, I am Dr. Carlos Schenck of the Minnesota Regional Sleep Disorder Center, located at the Hennepin County Medical Center in Minneapolis. This program will address a new development in sleep medicine and human behavior. Here at our center, we have discovered a new and potentially dangerous and easily misunderstood parasomnia, which is the branch of medicine concerned with unusual sleep behaviors. Before we learn more about this condition called the rapid eye movement sleep behavior disorder, let me ask you, the viewer, how you would react upon hearing that a man was regularly punching and kicking his wife at night in bed while dreaming that he was being attacked and fighting to save his life. Suppose you are a physician and a patient reports that he has tied himself by a rope to the bedpost every night for 8 years to keep him from leaping out of bed and becoming injured during violent nightmares. And what if other patients mention that they usually retire at night to a sleeping bag or to a padded waterbed in order to protect themselves and bed partners from their wild, dream-enacting behaviors? What explanations come to mind to account for such bizarre nocturnal events? As it turns out, there is a medical cause and a simple and safe medical treatment for this type of striking, dangerous sleep problem. Since 1982, for the past 5 years, During the course of routine clinical practice as physicians, we have evaluated 30 patients afflicted with the rapid eye movement sleep behavior disorder. This condition has received official recognition by the Association of Sleep Disorder Centers. These 30 patients, usually very calm and pleasant middle-aged or older men without psychiatric disorder, presented for help on account of violent dream enacting behaviors during sleep, which resulted in numerous injuries to themselves and their spouses for up to 20 years before their sleep problem was understood and proper treatment initiated. Their injuries included bone fractures, lacerations requiring stitches, and deep bruises. Many had been previously misdiagnosed by their physicians to have a psychiatric disturbance or epilepsy, and at times some received extensive therapy for these presumed disorders.